My name is Dawn Marie Galantucci, and I'm a dental hygiene instructor, but also first and foremost dental hygienist, and I have been for well over 20 years. So I'm very happy to be able to share my passion of perio with you. For those of you that are dental hygiene students, I welcome you to the best profession out there, and I know that you have a lot on your plate, and so I thought making this video would help you study for your boards, because there are a lot of great points in here. Perio is a big focus of the exam, and so I hope this does help you out. Those of you that have been hygienists a long time, it's a really great review, because when you come out of school, you have all this knowledge, but then as time goes on, you start to forget these little details of anatomy and so forth. So I hope this gives you a little bit of a refresher. Peri just means around, and odontos means the tooth. So it makes sense, because the periodontium, it's the functional system of tissues surrounding the teeth. It's what attaches your teeth to the jawbone. The periodontium is also referred to as the attachment apparatus or the supporting tissues of the teeth. The tissues of the periodontium include four main areas. It would be the gingiva, the cementum, the PDL or periodontal ligament, and the alveolar bone. And you see them pictured on the bottom right in this diagram. What's important about this is that you see how they're all closely integrated together. The gingiva has four anatomical areas: the free gingiva, the gingival sulcus, the interdental gingiva, and the attached gingiva. We're going to discuss all of these. The gingiva itself, it just provides a beautiful seal around the cervical portions of the teeth. In health, of course, we're talking about in health, and the alveolar process of the jaw. Now, in health, it's also known as the marginal gingiva. It fits very closely around the cervical areas of the teeth. It forms the soft tissue wall of the gingival sulcus. But note that the free gingival groove is not the same as gingival margin or mucogingival junction. In health, you're only going to be able to probe 1 to 3 millimeters, okay, into that sulcus. In health, you're going to have little to no gingival sulcular fluid or gingival curvicular fluid. It seeps really from that gingival CT or connective tissue, but it increases this fluid. You'll have more of it when you have inflammation. So for those of you that are in the dental hygiene clinic, just starting to see patients in school, you may have easy patients right now, but as you progress, you'll have harder and harder patients with more calculus, and that's where you're really going to see that fluid, okay? And there's a reason it's there, and you'll learn more about that in another lecture. But there are test strips out there that can be used to estimate the amount of fluid and the pH in that sulcular fluid. The base of the sulcus is formed by the JE, or the junctional epithelium. It is specialized epithelium that attaches to the tooth surface. The interdental gingiva is so important, because this is what fills the area between the adjacent teeth apical to the contact area and prevents food impaction. So one of the main complaints of our periodontal patients, especially those that have had any kind of periodontal surgery, is that they're getting food caught in between their teeth. Well, this is because they have lost this interdental gingiva. The interdental papilla comes to a point on the facial and lingual surface, and that's, of course, has to do with when we measure recession along the tooth, depending on how much interdental papilla they have lost. The caul is that area between the facial and lingual surfaces of the papilla, just beneath the contact area. It connects the facial and lingual papilla, so it's important when you are doing your periodontal probing that you are getting into that caul and you're angling your probe correctly. Again, a picture of the caul. It's a depression, okay? So between the palatal or lingual and facial papilla, okay? Healthy gingiva, we learn this, right from the get-go, that the color is pale pink, coral pink. It fills the space, though. That's what I really want to point out with this picture, talking about that interdental gingiva, is that it really fills the space between the teeth and does not bleed when being touched or when you're probing. There's no plaque. So virtually none of our patients look like that, do they? Most of them have some biofilm or plaque. The attached gingiva, we see the segmentation here, where the attached gingiva ends, and you have your mucogingival line and then you have your alveolar mucosa. You can easily see that when you retract the lip, you can see the segmentation in your patient's mouth. And then, of course, we have our marginal gingiva right along the gum line there. The attached gingiva is connected to the alveolar bone or the cementum. It's between the alveolar mucosa and the free gingiva. And we know in health, we want to see all our patients having the pale coral pink. The only variation of that is our the certain ethnic cultures, their gingiva is going to have a pigmented color to it, light brown to black, which of course we know is normal. They may show stippling. Gingival tissues, you could see what the diagram is showing at the very top is the alveolar mucosa. Then you have your mucogingival junction, the attached gingiva, free gingiva, and then the interdental gingiva. Pigmented gingiva is very common. We've all seen it. Those of you that are in school, you may not have had the opportunity yet to see it, but you will. And again, it's just another, just a gingiva having that pigmentation, melanin pigmentation. The attached gingiva, this is a really important point because boards love to ask this, where it's the widest. The width of the attached gingiva, it's widest in the incisor and molar regions. It's narrowest in premolar regions. We don't measure it on the palate simply because clinically it's not really possible to determine where this attached gingiva ends and the palatal mucosa begins. We have the masticatory mucosa. It forms 25% of the surface area. It is keratinized, so we know that means it's rigid, tough, tightly bound. Protective covering of it's the area that covers the components of the gingiva, the hard palate, and the alveolar ridge. The periodontal ligament, one of the most important pieces of the puzzle in looking at when we're doing our periodontal assessments, we have to be aware of what the radiographs are showing us as far as the PDL. Because when we look at that PDL, if any of those functions have broken down and the PDL is widening, the light bulb should go off in our head that this patient is either a perio patient or they're severely bruxing or both. So we want to really make sure that you have those radiographs up when you're assessing your patients for perio or just doing their perio assessment. But the 5 functions, and this of course is also something boards likes to ask about the PDL. We're going to get into another aspect of it that they focus on, but first we'll talk about how the PDL is supportive, sensory, formative, protective, and nutritive. Okay, and we're going to go into these again. The PDL connects the cementum covering the root to the bone of the tooth socket. Made up of fibrous bundles, collagen, which you know is important, building blocks of the tissue. It acts as a shock absorber. So imagine if any of you run out there, you're runners, and you had brand new sneakers that you're running with, and they have great shock absorbency. Well, what happens after a few months of using those on a daily basis? You need to replace them because that shock absorbency is not good, and you're going to damage your joints and your back. Well, the same thing with the PDL. If there's excessive bruxing and the PDL takes the brunt of that, but it also starts to break down because it only takes so much force if the force is not distributed properly. The principal PDL fiber groups, there's 5 of them: the interradicular, the apical, oblique, horizontal, and alveolar crest group. And you'll see that they're nicely colored in this diagram. And again, it's just shown in a black and white picture, but it also breaks down the different fiber groups. So going over these functions a little bit better, when we say supportive, it suspends and maintains the tooth in its socket. It's so important. And so when that starts to break down, what do we get? Well, we get the tooth becomes loose. Then we start to also get alveolar bone loss. The sensory portion of it provides sensory feelings such as pressure and pain. I'm always telling my students to think outside the box. Well, let's say you have a patient that comes in, and the reason why I bring this up because of the sensory portion. You have a patient that comes in, they've had root canal on a tooth. They're having pain in that tooth. So they think in the tooth. And they complain to you that they're having, pressure sensitivity there. And they proceed to tell you, well, how is this happening when I've already had a root canal? Some of you might be nodding your head because you've had this scenario happen in private practice. But what patients don't realize is, yes, when they have a root canal, they have no feeling in the tooth, but there's still the PDL. So the PDL is you're still feeling pressure and pain. So particularly, a lot of these patients that come in, it's bruxing. It's because they're grinding, and so now their PDL is reacting. When the PDL breaks down, the nutritive portion, where it's so important, it provides nutrients to the cementum in the bone. So we're starting to remember now, right? Those of us that have been out there a while, that this PDL is so, so important. It's formative. It has wonderful cells, builds and maintains the cementum. So cementoblasts, fibroblasts, and it really is so important. So, so important. And then there's resorptive function in response to severe pressure, where cells of the PDL can induce rapid bone resorption and sometimes resorption of cementum if you have those osteoclasts in there. When the orthodontist, when you bring your children to the orthodontist, or maybe some of you work for an orthodontist, they're trying to manipulate some of these fiber bundles so that the tooth will move, but they have to do it in a way that they don't damage. Those of us who've been out in private practice for a while, how many of us have seen a resorbed root? And more often than not, it's due to orthodontic force or it being done too quickly. And so we've all seen it. We all fear when we bring our children to the orthodontist that this will happen. So how important it is that everything's done nice and slow with that. But those fiber groups there's fiber groups that are involved with that. The cells of the PDL, the majority of the cells are fibroblasts that maintain the PDL fibers. Also living cells, such as the osteo and cementoblasts that build cementum and bone through life, okay? Then there's also osteoclasts. When they're in there, there's pathologic resorption. Sharpie's fibers, this is what I was speaking about before when I said about the different fiber groups. Sharpie's fibers, I can almost guarantee you will be on your boards. They always ask about them because they're very important. They're embedded in the cementum. You need to know that. And they're embedded in the cementum and the alveolar bone. Sharpie's fibers are, again, it's just broken down histologically. Okay, so you can get a better idea of what they look like. The supragingival fibers are made of collagen. They're arranged in bundles named by the structures they connect. And then you also have your alveolar gingival, dental gingival, transeptal, and circular as well. The epithelial-connective tissue interface. So the ridges of the epithelial tissue extend into the CT, or the connective tissue below. What this allows for is better adhesion and blood supply from the connective tissue to the epithelium. Another name is retiridges or retipegs. When there's inflammation, however, the balance is thrown off now. These retiridges extend deeper into the connective tissue. They're trying to stay connected and increase circulation to the epithelium. That's what they're trying to do. The junctional epithelium in health, let's talk about that a little bit. It forms a seal between the sulcular epithelium and the tooth, 0.71 to 1.35 millimeters long, 15 to 30 cells thick. But then as it gets towards that apical end, those cells taper off to about 4 to 5 cell thickness. The JE is a protective barrier. Okay, very important. It's protective between the oral bacteria and the perio tissues. Okay, when that starts to break down, this is when you get more of an invasion of that bacteria. And it's non-keratinized. So in health, it's very thin. There's no retiridges. It's only 2 cell layers. So what is the function? It attaches to the tooth with an internal basal lamina and the hemidesmosomes. So it attaches to the connective tissue with an external basal lamina and the hemidesmosomes. And it you want to think of it as a Velcro versus like a Velcro to fabric versus Velcro to Velcro. We know when you put two pieces of Velcro together, it's almost impossible to get them apart. So that's what we want to have. The connective tissue plus the epithelial tissue equals a natural or healthy biological width of 2 millimeters. Okay. Why do we need to know about biological width? Well, biological width is very important, especially when restorations are being done on the tooth, crowns, fillings, and so forth. When that biological width is invaded, we start to have periodontal issues, inflammation. That's not reversible unless the biological width invasion is removed. There's a biological space, and if it's invaded and it goes beyond what it should, that 2 millimeters, then we start to see breakdown of the periodontal tissues. So the distance from the JE to the periodontal ligament is 2 millimeters. Okay. Well, and like I said, it can be violated or damaged by restoration margins. We've all seen it. Those of us that have been out in private practice a long time, if we've worked for someone that sometimes they don't use a band in between when they're doing their fillings, or the patient just has a very deep filling, as you see in this picture here in this radiograph. However, the problem with that is the patient cannot keep that clean. Okay. Whereas it looks very, it looks like an okay contact where they can get floss in there. They really can't. And if you notice, they have an area of decay under that filling there because the plaque and the bacteria is just staying under there. And it's just the tooth has a very poor prognosis. And the gum tissue, of course. So keratinization, it surfaces the gingiva exposed to the oral cavity. All those that are exposed are keratinized. Cells have keratin granules. Fully keratinized cells lose their nuclei. Parakeratinized means, of course, it's partially. So just think of that word, para, and partially keratinized. They have keratin granules and still has a nucleus. This is breaking it down histologically, the keratin layer. You see how thick that is. Keratinized tissues of the periodontium. This is also something you need to know. Attached gingiva is keratinized, the interdental papilla, the palatal and marginal gingiva. Non-keratinized would be the sulcular epithelium, the JE or the junctional epithelium, and the caul. Let's talk a little bit about the cementum. It's thinnest at the cemento enamel junction, or CEJ, and it's thickest at the apex. It's similar to bone. It's such a vital support system in our body. It's resistant to resorption, unlike bone. It receives nutrients from the PDL, which we talked about. No nerve, lymph, or blood supply. It anchors the PDL fibers to the tooth and covers and seals dentinal tubules. We're going to talk a little bit about cellular and acellular cementum. Okay, something the boards love to ask about. And I wrote NBQ because it definitely is something that's on your boards. Types of cementum, acellular versus cellular. You need to know the location of where each one is. So the acellular, cervical third to half, cannot regenerate if removed. It contains many Sharpie's fibers. So you need to understand that the Sharpie's fibers, many of them are in the acellular cementum. Attachment to bone is strongest here. Now the cellular cementum, the apex contains cementocytes. It produces new cementum throughout the life of the tooth. It has fewer Sharpie fibers. There are variations in this cemento-enamel junction. Cementum overlaps enamel, it's most common. Cementum meets the enamel, and then there's a gap that exists between the cementum and the enamel, exposing the dentin, and this is in 10% of the teeth. So we have variations in the CEJ as pictured here. The alveolar bone, there's the alveolar process, which equals the alveolar bone. Okay, it's the bone of the maxillary or mandibular jaw, supports and surrounds the roots of the teeth, depends on the presence of teeth. Example, I mean, if you don't have your tooth structure in there, you're going to get resorption. Without healthy alveolar bone, you do not have support for your teeth. And this is just an example of what the alveolar process looks like. All right. The function of the alveolar bone. It forms the bony sockets. This is your support and protection for the roots. The alveolus is the socket. The alveoli is just plural, bony sockets. Alveolar bone proper contains numerous holes, allows blood vessels from cancellous bone to connect with vessels of the PDL space. The ends of the Sharpie's fibers are embedded in the alveolar bone. And we have a nice picture of the alveolus here. Beautiful support system in our body. And without that good support system, that is when we start to talk to our patients about periodontal disease and why they're having this disease situation in their mouth and why they're losing their bone. So we see an example just of what the alveoli look like. The crestal contour of the interdental bone, it's an indicator of periodontal health. So when we have a healthy patient, the interproximal bone is parallel. So with a line drawn between the CEJs of adjacent teeth. And this is exactly what I'm talking about right here. Okay. And we see the bone. Okay. Now this is where we start to see bone loss. And this is actually an example. Tooth number 20 has vertical bone loss, which is a more aggressive type of periodontal disease, but just showing that the bone loss, where in the previous picture we saw the healthy bone. I show this picture because I've been around a lot of biologic width invasion in my career. And I've seen a lot of bone loss due to the fact that the patient just cannot keep the area clean. If you look at number 30 and 31, they have huge buccal fillings. Can you imagine, just trying to imagine in your mind, clinically seeing that on a patient? It's no wonder they have bone loss around those teeth. Defects in alveolar bone, you need to know what the difference between dehiscence and fenestration. You have to memorize that dehiscence is the cleft-like defect, okay? Fenestration is that window-like defect, and I'm going to show you a picture right now. You see the difference between dehiscence and fenestration. Fenestration, it looks like a window into that root, and dehiscence is that almost like that notching there. Nerve supply to the periodontium. I go over this because it is part of the anatomy, but that's a whole nother lecture about about the nerve innervation and all that. But just some basic overall understanding that the maxilla has the second branch of the trigeminal nerve, the maxillary nerve, cranial nerve number 2, mandible has the third branch, the mandibular nerve, cranial nerve 3. Okay, and the nerve supply to the periodontium, it just occurs via the trigeminal nerve. You need to understand that. Another name for that is the cranial nerve 5. Functions of the nerve supply to the periodontium. Well, nerve receptors in the gingiva bone and PDL, what do we feel? Well, like I said before, even if a patient's had root canal, they still have feeling in their PDL, in their gum tissue because of the PDL. They register pain, touch, and pressure. What do the nerves do in the PDL? They provide information about movement and tooth position, so chewing. Innervation of the gingiva, the maxillary arch, the superior alveolar nerves provide innervation to the teeth in the PDL. On the mandibular arch, it's the inferior alveolar nerve provides innervation of the teeth in PDL. So this is just a nice little diagram of the nerve supply of the periodontium. Blood supply, the major function of the complex blood vessels we know what the function of blood vessels are. They transport oxygen and nutrients to the tissue cells of the periodontium to remove carbon dioxide, and then there's other waste products that also need to be removed by these blood vessels. Vascular supply to the periodontium. The maxillary, gingiva, PDL, and bone. That is from the anterior and posterior superior alveolar arteries, the infraorbital artery, and the greater palatine artery. The mandibular, gingiva, PDL, and bone would be the inferior alveolar artery, the branches of the inferior alveolar artery, which is the buccal, facial, mental, and sublingual arteries. And this is just a nice diagram of the vascular supply to the periodontium. Such an intricate system. One worth reviewing, though, to help treat our patients better. This is our main goal. Superior alveolar arteries supplies to the maxillary tissues, periotissues, and the inferior alveolar artery supplies to the mandibular periotissues. The lymphatic system and the periodontium, it's very important to understand that there's a network of lymph nodes connected by lymphatic vessels, okay? Why I bring this up, it's part of our anatomy, and it plays such an important role in our body's defense against infection, okay? They filter out and trap. They're so important, these lymph nodes. They trap bacteria, fungi, viruses, etc., and eliminate them from the body when they're healthy, when the lymph nodes are in a state of health. The lymph from periotissues is drained to lymph nodes of the head and neck. Example would be a good example, third molar infection. Often I've had patients over the years that have come in with swollen lymph nodes, and it's due to third molar infection that has just gone on and on. And this is just a nice little overview of the lymphatic system of the periodontium. Well, I certainly hope that that you've had a really great review, and I encourage you. There's a wonderful video on YouTube. A great group called osmosis.org, and they produce a lot of great videos about gingivitis and periodontitis. But if you'd like to take some time to look at my website, it's called dentalhygieneinsights.com, and there you'll find a lot of great blog posts about the newest trends in perio. I welcome you to visit that, and also to subscribe so that you'll be able to get the newest blog posts on a weekly basis. And also, I'd love to hear from you. In my website, there's a discussion forum. If you have any questions or anything, I would love for you to leave those questions and hear your thoughts. I hope you enjoyed this review, and I look forward to posting more videos on YouTube about periodontology.